All right, Landon, hit the disclaimer.
First, just start with acne. I feel like that is probably the most common thing that I have seen on your schedule to be managed. And even whenever I'm looking to see an acne patient, if they came to me, I would look up to date, and it would maybe say 4% benzoyl peroxide, and I would try that and put a referral into derm and hope I'm not following up with them.
Yeah.
What is your approach to seeing an acne patient, and what are you looking for? What are the different types, if that would make any difference from your management, and what can they expect with your treatment and treatment recommendation?
Yeah. So first, I'm going to initiate and assess the patient and a couple of different things. Genetically, ethnicity-wise, what age are they? Was this a sudden onset or has it been something long-term? And the type of acne is going to be what gears my approach of treatment. So with acne, you have a few different types. Comedonal is going to be open and closed blackheads, whiteheads, and then which would be a more mild. You can have a mild variation of that covering face. You can have a severe covering head to toe. Worsening of that would be when you have more papular pustular acne, which is going to be more pustules, more inflammatory bumps. And then a more severe variation of that is going to be when you have cysts and nodules that are going to be much deeper under the skin and sometimes in combination with comedonal acne. So the type that they have, the age that they are, and where it's located is what's going to gear my treatment. That being said, there is not always a quick fix to this, and this is the difficult part about treating acne patients. It's typically going to be a lifelong journey. A lot of the time we're seeing young kids that are 15 and 16, and yes, most of the time they kind of grow out of that by their 20s, but sometimes genetically our oil production in our pores just predispose us to acne lifelong. That being said, you can also have the deeper, more pustular, inflammatory type of acne that is hormonal and that does kind of pop up later in life. And so that's a little bit of a different entity in how we treat that. But starting on a basic level, you are definitely going to have your benzoyl peroxide, and that's typically a go-to because it is typically tolerated pretty well. Benzoyl peroxide is going to work on decreasing the bacteria that is caused by acne, and it helps to oxygenate the skin. Sometimes that can be at fault, though, and that can sometimes worsen acne initially. It can cause some redness and some burning, sometimes to a severe level where they cannot tolerate it. So we reserve the higher strengths. You have 4% and 10% typically. 4% is going to be more for the face. 10% is pretty harsh, and some people do use that on their face if they can tolerate, but that's going to be more for body acne. In addition to benzoyl peroxide, topical antibiotics like clindamycin and azelaic acid are also used for acne. But what these are doing are, again, targeting the bacteria that's causing acne. They're not preventing acne. When it comes to preventing, we then move into the retinoids. So the combination of benzoyl peroxide and antibiotics can be very helpful. But we also want to prevent their acne. We don't technically want them to be on this stuff forever, but retinoids or retinols are going to be what I would call our workhorse for acne. These are the medications that open our pores, clear them out, and prevent them from refilling. So this is what's going to treat their acne and prevent their acne, which is what anyone with acne wants. So these are the medications that create a peeling and purging process. So it makes your skin over a 27-day time frame start to peel. And in the peeling process, it's slowly pulling everything out of the pores, which is when you get a purging, which is when all the stuff in your pores is starting to slowly come out. And then the goal is to keep using it to where it prevents it from refilling. So these range in strength from very, very low strengths over-the-counter adapalene to middle grade strengths like tretinoin to higher strengths like Tazorac, and then even oral retinoids like isotretinoin or Accutane. So that obviously is going to range based on their severity. Obviously, somebody with cystic nodular acne is going to need a Tazorac or an isotretinoin. Somebody with mild comedonal acne is going to need a Dapiline or a low-dose tretinoin. But the big thing about acne that I think is difficult in the beginning of treating it is what I call the suck it up phase. When you first start this routine, you're going to experience a variation of redness, burning, stinging, peeling. And people think, I can't tolerate this, my skin is too dry. But really, it's exactly what the medication is doing. It's creating this shedding or this peeling process. And the only way to get past that is to continue using it. So people have trouble controlling their acne because they start and stop and they start and stop, or they're only using their retinoid a couple times a week. So they peel for a few days and then they stop. And I have to kind of educate how the medications work so that they know, okay, this is supposed to happen. I need to stick with this. And then the peeling stops. And that's when they're in that continuous state of creating skin faster. And that's how we treat the acne. During that phase, which is anywhere between 1 to 3 months of starting a skincare routine, we usually couple the rest of the routine with being very gentle. So gentle cleansers, gentle moisturizers. We don't want harsh acids or too much exfoliation. The routine is typically very gentle while we're getting used to medications, 2 to 3 months. Then once they're used to that and they're not peeling or red or burning anymore, then we can reintroduce other beneficial ingredients like acids, like salicylic acid and glycolic acid. But the beginning is crucial because this is when your skin is remodeling or readapting to what the new treatment plan is going to be. But if you don't do that right and you start, stop, or you add in your own things, you could make your side effects a lot worse. You can really worsen peeling and burning. You can cause blisters and scarring and infection even if you're not doing it, as advised. So sticking to that regimen and that routine is really important for the beginning part of that acne treatment. And then following up is going to be key. We usually follow up every 3 months because it can take 2 to 3 months to get the full effects of the strength of the medication and how it's working. So if you come back to me in 2 weeks and say this isn't working, I can't assess that was really a failure in treatment because it was not technically long enough for the meds to have worked. We typically see them every 3 months and reassess how they're using it, if they're using it regularly. And a lot of the patients are honest and they say, I'm using this once a week. And I have to be, straightforward and say, that's not how this is indicated and you're not going to get effects from using it that way. So I think that's a big part of starting with the acne and getting people on the appropriate routine. Typically, after 3 to 4 months, you kind of know what's working and what's not. If I have somebody that comes to me and they're on a pretty good routine and they're doing it religiously and their acne is still not really well controlled, then I kind of look at my alternatives of what else do we need to go up in their retinoid strength, or do we need to add something else? When we have inflammatory pustules and nodules and cysts is when I sometimes couple in oral antibiotics like doxycycline, because not just for bacteria purposes, but for inflammation. So doxycycline works really well on the inflammation that's causing the nodules and cysts in addition to the topical routine. So that would be what I call like putting the fire out. It's not going to be something they're on long term for years, but it is what's going to kind of put that fire out while their topical routine is starting to work.
And you don't want to be picking, or if you have them, pop them, because I've never done that.
Correct. No, so that's a big thing that I tell everybody. Things to avoid with acne is going to be picking and popping, and we've all done it, and it's really hard not to be honest. But picking and popping actually contributes to acne. Let's say you have one pimple and you pop it. That bacteria and that stuff goes into the skin around it. You may have 5 pimples the next 2 days. So you're literally multiplying the amount of bumps. And if you don't get it out, sometimes it goes down into the skin and then it causes an inflammatory bump where it may have just resolved in a couple days. So big things to avoid. You want to avoid touching your face at all costs. There's just no need to touch unless you're doing your skincare routine. Avoid picking. Picking or popping can lead to worsening acne, hyperpigmentation where you have a darkening there, scarring that can be very difficult to treat after the fact. You also want to avoid devices. You don't need a washcloth, a loofah, a spinny brush. You don't need any devices when you're washing your face. You can use just your hands and your product. Changing your pillowcase. You want to avoid stopping and starting skincare products. Trying something for a week and then trying something a week later because that didn't work is just not how the skin works. It takes consistency and time for skincare products to actually work. So that's a big thing to avoid. When it comes to dietary restrictions with acne, there's not a ton of research to prove that there are lots of things that contribute. A lot of people think it's all sugar, and yes, sugar can be a small component, but main things that there are science behind is going to be some sugars, some whey proteins like animal proteins, and some milk, some dairy products. So I found that, I was drinking a whey protein shake every day, 2 to 3 times a day. And when I stopped that, my acne got better. And also, there's other things that can help acne aside from prescriptions. Microneedling helped my acne immensely, almost more than certain skincare products did. Chemical peels, microneedling, sometimes even lasers, certain things like that can really help with acne as well.
From a hormonal standpoint, for women, I've seen birth control and then also spironolactone. Mm-hmm. When do you bring in any of those, and does it fluctuate with their cycle? Do you cycle them at all, or do you just keep them?
So I would say I start to think about that. One, if they're resistant to treatment, where nothing we're doing is really working, or their acne really flares. Sometimes it's not on their menstrual cycle. Sometimes it's before and sometimes it's after. But if they really seem to flare in any of those phases, or let's say that they're never had acne, they're 40s or 50s, and they've got this new onset adult acne, is when I'm going to start thinking hormonally.